welcome everybody. I'm sorry that we're slightly late in starting. My name is Kate Stevens and I'm a nephrologist from the UK. So this is one of our sessions from the ERA, the European Renal Association, joint with GLOMCon. And it's on a very important topic that is becoming increasingly important in renal medicine, so imaging. And we've got a great lineup. So our speaker today is Dr. Menno Pruyum from Lausanne in Switzerland. And then on our panel, we have Professor Sue Francis, who is a physicist from the Sir Peter Mansfield Imaging Centre in Nottingham. And Sue has very kindly agreed to chair the discussion following Menno's talk. So joining Sue, we have her colleague, Dr. Charlotte Buchanan, who's also a physicist and also works in Nottingham alongside Sue as a postdoctoral research fellow. We're delighted to have Professor Nick Selby, who's a Professor of Nephrology from Nottingham University and the Royal Derby Hospital. Renal imaging is just one of Nick's many areas of interest and expertise. And then finally on our panel, we have Dr. Keith Gillis, who's a consultant nephrologist from Glasgow. So all of our panellists are members of the UK Renal Imaging Network, and in fact, Prof Selby and Prof Francis are co-chairs. So without further ado, I think if Menno is ready, we will hand over to him, and he's going to present magnetic resonance imaging for us today.
Welcome everybody, and sorry so much for this slow start. In the following 30 minutes, I'm going to talk to you about the magical world of magnetic resonance imaging and focus on functional MRI and mainly bold MRI that is capable of measuring renal tissue oxygenation. I will tell you why this is interesting to do, how we do it, and how we could use this in the clinic. As we are a mixture of nephrologists, I suppose, maybe some physicists, I have a few introducing slides on how kidneys function, what is CKD, and I also have for the nephrologist a few slides on the basics of MRI. Next slide, please. Conflicts of interest, we can skip this. So, kidneys are wonderful organs. They have the size of a smartphone, but they receive huge amounts of blood. You may know up to 800 liters per day, and about 180 liters of this is filtered by the glomeruli. Glomeruli are part of the nephrons, the mini filters in the kidneys. You have 1 million per kidney. And once the blood is filtered, the primary urine arrives in a tubular system, and these tubuli altogether have a length of about 8 kilometers and will reabsorb more than 99% of the water and many of the electrolytes filtered. For example, you filter 1.5 kilo of salt per day, and as you may know, only 5 to 10 grams ends up in the urine. Next slide, please. Now, this is a sophisticated mechanism, so you can understand that sometimes things may go wrong. So many systemic diseases can damage the kidneys, and we usually classify kidney disease states as pre-renal, renal, or post-renal, but in a way, the end result is always the same. The glomeruli are going to be damaged, and this leads to glomerulosclerosis, and the tubuli and the interstitial tissue around it will lead to interstitial fibrosis, and the kidneys in general shrink, maybe accepted diabetes. Next slide, please. Once you have lost a certain number of nephrons, the kidneys will decrease their functioning, they will start to dysfunction, and this is usually measured with the glomerular filtration rate, and by definition, a glomerular filtration rate below 60 or the presence of albuminuria is considered as chronic kidney disease. And this disease state touches 10% of the Occidental population. It's a very silent disease. Most people are not aware that they have it, yet CKD is an independent predictor of cardiovascular mortality and death. Next slide. There are in fact two major problems with CKD. First of all, putting the right diagnosis without performing an invasive biopsy is difficult. And the second problem we have is predicting its outcome is not very precise. It's like playing darts. You never know if you're going to know what's going to happen where the arrow goes. So on the left side of the slide, you see different evolutions of patients. Some remain very stable, others first remain stable, then decline their renal function. And basically, we don't know. We see many patients smiling to them, asking them to come back 3 to 6 months later and to notice that they're still stable. And this is possibly because the actual biomarkers are not very precise to detect kidney damage. And what would really help us to have new biomarkers that provide information on what really takes place in the kidney, how they are perfused, is there a lot of inflammation, fibrosis, and of course, glomerulosclerosis. Next slide. Could MRI help in this? On the left slide, you see under the letter T a big tumor, and we basically know that MRI is very good to identify tumors, to classify them. So it gives really anatomic images with high resolution. And at first sight, they're not going to be very useful to identify CKD. On the right side, you see under A, kidneys of somebody with normal renal function. Under D, somebody with pre-terminal kidney disease. And the only thing that's different is, of course, the size is smaller. However, next slide, please. Things have changed, and over the last 2 decades, functional MRI has entered the world of nephrology, because we can measure with this functional MRI different aspects of the kidney. We can measure, for example, renal artery blood flow, as shown on the left side. With phase contrast MRI, we can now measure the cortical and the medullary perfusion with arterial spin labeling. We can measure the degree of inflammation or edema with T1, T2 mapping, and we can even estimate the degree of interstitial fibrosis, so we think, with diffusion-weighted imaging. We can also measure, and that's what this talk is about, tissue oxygenation with bold MRI, and you might wonder why this is interesting to do. Next slide. This is interesting because renal kidneys live on the edge of ischemia. The PO2 in the cortex is as low as 50 millimeters of mercury, in the medulla between 10 and 20. So you can imagine that if anything happens with this oxygenation, kidneys will soon have kidney damage. Next slide. And this is indeed the case for acute kidney injury. The classic example will be acute tubular necrosis, but also in CKD, it's become clear in animal studies, according to the chronic hypoxia hypothesis, that this may play a role. If you look down on the left slide, you see that the loss of glomeruli will lead to poorly perfused tubuli, because the perfusion of the tubuli depends on the efferent arteriole coming from the glomeruli. So tubuli will have ischemia. This will stimulate interstitial fibrosis, and this interstitial fibrosis will lead on its term to further glomerulosclerosis. So it's a sort of a vicious circle, which is known as the chronic hypoxia hypothesis in CKD. Next slide. Thank you. So measuring oxygenation of the kidney would be interesting, and in animal studies, this is not so difficult. It's done with micropuncture studies, but you can imagine this is not very nice to do in humans, and I don't think there are many who would like to undergo this procedure. Next slide. Luckily enough, in 1996, Prasad and his team came up with the first paper called about a bold MRI. I didn't have a picture of Prasad, so I put a picture of a nice Swiss watch here. And this was really a landmark paper I'm going to explain to you now how this bolt MRI works. Next slide. To understand it a bit better, a few basics about MRI for the nephrologist this time. So an MRI is a big magnet with a magnetic field, and any atom with an uneven number of protons or neutrons will have what we call a magnetic moment. So this means they behave a bit like mini magnets. And once you put the human body in an MRI, the most abundant atom of the human body is hydrogen. The hydrogen mini magnets will align according to this magnetic field. One click, please. This magnetic field can be altered by giving radio frequency pulses. Please, Kate, can you press once? And this will change the magnetic field. And when these hydrogen mini magnets change position, they will increase the energy level, emit a signal that we can capture with the MRI antennas, and we can follow the intensity of the signal over time and follow the repositioning of the hydrogen atoms in their original position. We do this in two directions, basically. We have the T1 relaxation time, that's the time when 63% of magnetization has recovered longitudinally. And we have also T2 relaxation time, defined as the time till 63% of the transverse magnetization has decayed. T2 star is a special form of T2 star, if you want, because of T2, if you want, because there's a difference between the observed T2 relaxation time and the true T2 relaxation time, because magnetic field inhomogeneities can be induced by some substances, as by deoxyhemoglobin. Please, the next slide. And this is in fact the basic principle of bolt MRI. Deoxyhemoglobin, with its iron atom in the center, will shorten in fact the T2 star echo times and increase inversely the decay rate of the signal. So your signal disappears faster in a way if there's a lot of local deoxyhemoglobin. And with certain sequences, you can follow the disappearance of the signal over time, and for each pixel of your image, you can measure the decay rate R2 star. The faster the decay rate, the higher the R2 star, the higher the deoxyhemoglobin level locally will be, and inversely, the lower is your oxygenation. Next slide. Once you have your R2 star map, there are different ways of analyzing this. The classical way is to put circles in the cortex and the medulla, known as the regional Roy technique. And the mean value of all the R2 star pixels in the circles of the cortex and the medulla can be obtained by this, and this gives you the degree of oxygenation in the cortex and the medulla. Next slide. For those who want to know exactly how to perform the bolt MRI acquisition, I refer you to this consensus statement paper that was published this year by Octavia Bain and other experts in the field, published in MAGMA 2020. And this is some technical details about how it should, according to us, best be performed. So most centers will now use 3 Tesla. Usually the coronal plane is used because you have more kidney tissue to analyze at the hilar level. And most centers will perform the bolt MRI in breath hold to reduce movement artifacts. But of course, if you have navigators, you can also apply free breathing. Next slide. Applying this method, you get nice results. This bolt MRI has been validated in pigs that had direct measurement of PO2 with microelectrodes, and at the same moment a bolt MRI was performed, and in the graph you see a linear correlation between the PO2 of the microelectrodes and the R2 star values. Next slide. The method has also a good reproducibility. Here a few small studies showing MRIs performed in the same subjects, either several times on the same day or on different days, with acceptable coefficients of variations of this technique. Next slide. Now, it's a bit of a simplification to state that R2 star directly measures oxygenation because the R2 star value is influenced by many factors. Some of them are shown here on this slide on the left side. MRI-related factors, such as breathing artifacts or water-fat chemical shifts, so it helps to put your arms above your head if possible for the participants. Some are more patient-related, notably hydration should best be standardized and other factors as well. Now, once we have standardized, once we start our measurement, what are we going to do with this bolt MRI? Well, first of all, I think it helps to gain insight in physiological processes. Next slide. And I would skip this one, please. Sure. Recently, a Chinese group has shown that aging is not so good for the oxygenation of the kidneys. You could sort of expect this, and the cortical R2 star levels were higher in older participants, suggesting lower oxygenation in older people. This is not all. There are also differences between women and men, and women have in fact lower R2 star values in the cortex and the medulla, so better oxygenated kidneys than men. This is not only true in this study, we also have data from other studies confirming this. So, and of course, this makes you think, is this some protective mechanism that makes that women are less prone to kidney diseases than men? Next slide. Here, an elegant study using the hand grip. The hand grip is a nice way to stimulate the sympathetic nervous system. And this combined work of Copenhagen and Nottingham shows, in fact, that the change of R2 star measured with bolt MRI, while people are in the MRI holding the hand grip, stimulating the sympathetic system, so reducing normally the blood flow going to the kidneys, leads to an expected decrease in oxygenation of the cortex, but it did not lead to a decrease of oxygenation in the medulla. It even led to an increase. And this was explained by the investigators that maybe by reducing the blood flow to the kidneys, you also reduce the GFR, and so you reduce the oxygen consumption by the kidneys. So just an example to show you how bolt MRI can help you to understand better what takes place in the kidneys by different interventions. Next slide. What else can we do? We can see what's the influence of nutritional factors on kidney oxygenation. Next slide. Salt was our first experience with bolt MRI in Lausanne. We could show that both in normal and hypertensive individuals, R2 star would decrease when the subjects changed from a high sodium to a low sodium diet. And this decrease took place in the medulla, suggesting increased oxygenation, less metabolic workload probably, because less sodium has to be reabsorbed when you eat little amounts of salt. So this is a long way of saying that reducing salt intake is good for the kidneys. As we like chocolate in Switzerland, I always like to show this example. Next slide. We also did an experiment with chocolate and bold MRI, and we saw that the R2 star values on the left side in people eating 1 gram per kilogram of dark chocolate reduced the R2 star in the medulla, and the same individuals did the same experience eating white chocolate. So a baseline bolt followed 2 hours later by another bolt after they had eaten the white chocolate, and nothing changed. So dark chocolate is good for your kidneys, white chocolate is not. Next slide. We can skip this one. This is just a bit playing around, but of course the main question is, can bold MRI help to first confirm the chronic hypoxia hypothesis and maybe also help to predict outcome of CKD? Next one. And there we have a problem, because the classic placement of circles in the cortex and the medulla is difficult in patients with CKD that have corticomedullary dedifferentiation. And in fact, the reproducibility of this is very low if you take 2 observers, and you have to think of other ways to analyze your images in CKD patients. Next one. And there are different ways. Under B, you see a method we developed in Lausanne. We called it the telco technique, the 12 layers concentric objects technique, where all you have to do is manually select the kidney parenchyma. So you draw an outside line of the outer side of the kidney tissue and an inside line of the inner side. And then an algorithm will divide the kidney parenchyma in 12 layers of equal thickness automatically. And this gives you a mean R2 star value for each layer. Under C, you see that the R2 star will go up when you go from the outside to the inside. And it's exactly what we know from micropuncture studies, where the PO2 goes down in the medulla. And this is a very good method with excellent results if you ask 2 different observers to analyze this. The Mayo Clinic applied a different method. They called it the fractional hypoxia. You see it under D, where it's simply where you select all the kidney tissue by hand and you define the percentage of R2 star pixels with a value that they see as a threshold. For example, 30. Above this is highly ischemic value. You say, okay, now I have 5% of pixels above this value. Also works very well, reproducible, all fine. And on the right side, I just show you the whole kidney ROI placement, where all you have to do is you select all the kidney tissue and you get a mean value for this. So all these methods have not all the same success in CKD, and we in Lausanne, we prefer the telco technique for this. And with this technique, next slide, please, we could demonstrate in a cohort of 200 subjects that the R2 star level of the 3 outer layers of the kidney as obtained with the telco technique, so the cortex, is an independent predictor of EGFR decline. And on the left graph, it's in very small letters, but the only independent predictor of EGFR decline was the R2 star value of the cortex, and the other one was the degree of albuminuria. All the others did not predict in the 3 years of follow-up EGFR decline. And when you look at hard endpoints on the right side of the previous slide, in fact, people with R2 star values above the 90th percentile had 3 times more risk to finish up in dialysis than people with lower values. The Mayo Clinic uses Bolt MRI to see the effect of renal artery stenting and renal artery stenosis. And here you see a nice example of kidney oxygenation increasing after stenting with much less hypoxic pixels on the right side than on the left. Next slide. Last thing we can do with this is, and this is very interesting, is look at the effect of drugs on kidney oxygenation. We speak a lot of SGLT2 inhibitors lately. We did a study in Lausanne with empagliflozin, where basically the R2 star curves did not change at all when giving acutely empagliflozin, repeating this after 1 month of chronic intake. So we concluded that in these obese but non-diabetic volunteers, there was no effect of SGLT2 inhibition. I cannot finish this talk without one little word on furosemide. It's the classical drug used in Bolt MRI. It blocks the NKCC2 in the ascending loop of Henle. It will block sodium reabsorption there, and is used as a functional test of tubular function. Next slide. Because if you have a lot of functioning tubuli, the change in R2 star induced by furosemide will be very large. And here in this slide, you see that in people with normal function, this change is much larger on the right side than in people with CKD if you acutely inject furosemide and repeat the Bolt MRI 15 minutes later. Next slide. This brings us to one very important limitation, we can skip this one, of Bolt MRI, which is the problem of the blood volume fraction. Next slide. This is nicely illustrated by the group of Berlin. In fact, if you give furosemide, not only are you reducing oxygen consumption because of reduced sodium reabsorption, which is active transport, you also change in 1 pixel, and that's a bit the square on the right side, you change probably the amount of fluid because you will stimulate diuresis. So the size taken by tubular fluid in this 1 pixel will increase, whereas the relative contribution of the blood flow may decrease. And in result, the number of deoxyhemoglobin, here shown as little circles, will reduce, so you risk to overestimate the effect of furosemide. It's not only the change in deoxyhemoglobin, it's also the volume of fluid in this pixel that changes. And to overcome this, they developed a model called Mr. Physiology in rats, where they could measure at the same time with microelectrodes, PO2, renal blood flow, and so on, and perform MRI. And they saw, for example, that if you clamp a renal artery, this will not automatically lead to an increase in the R2 star because you reduce, again, the blood flow to the kidney, and the relative contribution of blood to this 1 R2 star pixel will decrease. They also found a solution for this, and they, next slide, they injected ferromoxetol. Can I have the next slide, please? We seem to be blocked, but we also, what they showed is that injecting ferromoxetol is an elegant way to have an idea of the amount of relative blood volume in the kidney at each time point. As ferromoxetol really stays in the renal circulation, it is not filtered, and the more ferromoxetol arrives in your kidney, the larger will be the change in R2 star, because ferromoxetol is full of iron, will acutely change your R2 star signal and will lead, so the bigger the change, the larger the blood volume fraction.
Sorry, Menno. Kate seems to have a technical problem, but I can share my own screen now, just for the last few slides that you've got. Is it the next slide?
It's okay. It's okay. I will just continue. This is the slide I wanted to show. So we should all memorize the formula shown on this one. No, just kidding. So we have to take this factor into account. And of course, another way of taking this into account is performing different techniques of MRI during the same session that could also measure the renal blood flow, for example, using arterial spin labeling. As I said in the beginning of this talk, we can really quantify corticomedullary blood flow, combine this with both MRI data, and understand better what happens. Next slide, please. And now this multiparametric MRI approach, I think, is very promising for drug research, because nowadays we give a drug, we wait for weeks, months to see if something happens with creatinine or with albuminuria. These are not sensitive markers, but if you give the drug just after having performed a baseline MRI, you repeat the MRI without side effects, without having to administer any contrast product a few hours later, you can already see if something happens with renal blood flow, oxygenation, inflammation, etc., and have a very early idea about the possible nephrotoxic or nephroprotective properties of drugs. And I see that more and more pharmaceutical companies are interested in this approach. And with this, I come to the end of my presentation. I apologize once again for the slow start due to technical problems. But to conclude, bolt MRI is an elegant technique to estimate changes in renal tissue oxygenation, but you have to take many factors into account for correct interpretation. And the pheromoxetol technique is, I think, also promising to use in humans to overcome the problems of change in renal blood volume. And I really think that combining bolt MRI with other functional MRI techniques is the way to go. I'm not the only one. Many people think this, and this will help us hopefully in the future to predict even better CKD outcome and uses in blood in drug research. Thank you.
Thank you. Thank you, Menno, for a great overview for both kind of nephrologists and physicists. So I guess now what we'll do is we'll just open to a panel discussion. So if anyone's got any questions, then please drop those questions into the chat. So we'll just get started then. So I'll kind of open up first of all just to ask a question myself, and then I'll open up to the panel. So the slides you showed some slides on SGLT2 related to BOLD. Do you think there's any, and I think in those slides there wasn't no changes resultant in BOLD, but what do you think about other parameters associated with SGLT2s?
Mm-hmm. Yeah, well, there are studies ongoing testing if other parameters may change because of SGLT2. I think the main effect of SGLT2 remains lowering glomerular pressure. That's really difficult to measure with MRI, and this is probably the main nephroprotective effect. So you would need long-term studies to see any influence on interstitial fibrosis, so with diffusion-weighted imaging. In the short term, it would of course be interesting to see if there's a change in the renal autoregulation, namely the blood flow to the cortex or the medulla. Would we expect any change here? As these drugs interfere by the tubuloglomerular feedback, this may be the case, and arterial spin labeling is actually tested to see if any changes occur on this behalf. And the handicap we had with our study is that it's really obese persons that are non-diabetic and we have to see if any changes occur in diabetic persons.
Great, thank you. We have a few questions coming in on the chat. So is there any way to differentiate between hypovolemic ATN from toxic ATN?
Hypovolemic from toxic?
Yeah.
Well, I think, first of all this MRI is difficult to apply to the acute setting, because you have to still transport them into the MRI. And if you look in the literature, there's not many studies. I know one German study, I think, looking into AKI and changes in R2 star. And in fact, what you see is that in acute tubular necrosis, whatever the cause, the oxygenation seems to improve in a way, and so the R2 star goes down, and this is probably because there's no more active tubular transport, so no oxygen consumption. But can we differentiate? I can imagine that if you would again use multiparametric MRI, because hypovolemic, you still expect a decrease in renal perfusion. So you could use for this phase contrast MRI, which would give you the global renal perfusion of each kidney. And if you see a reduce here, this would more be a hypovolemic form of ATI, I would imagine. If this is not the case, you would have an argument for some toxic origin, but this remains quite hypothetical. I don't know any studies having looked into this.
Great. I'm just going to go back to the chat. There's a few other questions there. I'm just going to go to a more physics-based question first of all. Can you say a little bit more about the interpretation of baseline R2 star and what it means in different regions of the kidney, and how do you differentiate oxygenation from magnetic field inhomogeneities?
Yeah, we have to be careful. That's of course the main message, and it's not like hemoglobin that you measure and everywhere people, well, even hemoglobin, if you give the sample to different laboratories, they may come up with a different result. For R2 star, if you have the same individual in different MRIs, they may have different R2 star values, because there's many technical factors, as we said. And you only see, well, differences between, for example, CKD that have higher R2 star levels than controls if you look with larger numbers, and there's a lot of overlap. So one single value is difficult to interpret, and you're better off doing some functional tests, like we like doing with furosemide, and look at the changes with the stimulus. That is more informative and will be more robust and more easy to reproduce in other centers than just the baseline value.
I think, Sue, as well, what Menno illustrated nicely in his talk, and what the broader audience who aren't familiar with MRI studies might not realize, is just how many steps there are between the renal physiology and a number that you get at the end of it. There's patient factors like hydration, anemia, nutritional factors, smoking, like Menno discussed. There's image acquisition issues, which are not standardized across different centers. And there's different image analysis techniques, as Menno reflected as well, which can create quite a lot of technical variability, which means that a single measurement of R2 star can be quite flawed. And I think what's moved the bold field on quite nicely is, as Menno's shown, the TLCO approach to image analysis, which uses a kind of internal standard. It compares it with a cortical measurement is compared with a medullary measurement to allow a kind of standardization. And that's been shown to have a greater predictive value in progressive CKD than R2 star values, just as a single measurement.
Keith, can I come in? I'd maybe go back to the AKI question, obviously close to my heart, but just sort of two comments on that really. The first, sort of to go back to Menno's point about that paradoxical increase in R2 star, sort of suggesting less deoxyhemoglobin. Could that be the sort of same phenomenon that you show, that there's less deoxyhemoglobin per voxel, maybe because of an effect such as edema? And that sort of links into the sort of second comment that we've sort of done recently looked at some pilot data in acute kidney injury, and you'd see the sort of the changes that you might expect with a reduced perfusion, but you see some really quite striking changes, and there was a dramatic increase in T1 values, which again might fit with that sort of inflammation edema type picture. But I guess one of the most surprising things was actually kidney volume was increased at the time of AKI, and over time some of those changes improved and normalized, but in other patients they didn't. So whilst MRI is challenging in the acutely unwell setting, it may also have a role to sort of follow these patients up and study that transition from AKI to CKD in some patients.
Yeah.
And I think we can expect to see some COVID data in that field as well before long.
Yeah.
Just a comment on that from my side. You hear me?
Yeah.
I do think, of course, you would say, oh, but acute tubular necrosis is a classic example of hypoxia. Why don't we find this? But we get them in the scanner too late. It's when the damage has already been done. And probably if you would get them in very early, I suspect there you would have a different picture. When there's not this edema net yet, you may have a phase where they are really truly hypoxic, but we have to work more with this blood volume fraction to interpret the results better, because in transplant rejection there's the same problem. The Sadowski papers that date now back from more than 10 years in acute rejection did not find an increase in R2 star as they expected, but a decrease, so an increased oxygenation. So let's always remain careful when we say R2 star is oxygenation. That's one of the basic messages, but it doesn't make bolt MRI less interesting. It does increase a lot our understanding of what's going on in the kidneys.
Could that be a factor of the male-female difference, do you think, as well, or is that's a true observation?
Yeah, it kills me, this male-female question. I haven't found the answer yet. I don't really know, because the renal blood flow in women is a bit lower, right? So I don't know how to explain it. Yeah.
What about hematocrit? How does hematocrit influence measurements as well?
I find its effect rather small in all the analysis we have done. I don't know what's your experience, but I find the influence of hemoglobin on R2 star not very large. I cannot explain it better than that. Probably we have a lot of reserve, as often in the human body, but doesn't play a major role according to me. There's always hemoglobin remaining to increase the deoxyhemoglobin significantly, probably.
And I guess the other question would be in terms of men and women, in terms of how the MR scanner, in terms of shimming and arms and B0 and those effects influence the absolute kind of effects on T2 star. I haven't really thought about those, but what do you think on those? Do you think that could have any influence?
Sorry, I just saw passing by the answer that women eat more dark chocolate. It's not the case. But sorry, the dark chocolate effect, by the way, is really linked to cacao, and because we had dosed the metabolites of cacao in the blood of the subjects in this study, and there was really a direct link between R2 star and the amount of metabolites of cacao in the blood. So the more catechins, epicatechins, I think that's the name of these metabolites you have circulating, the larger the decrease in R2 star was. So, but maybe they eat it secretly, the women.
So there's a few questions on the chat about the link between pathology and looking at link between MR measures and pathological correlations. Do you want to go into a bit more detail on that and have a brief discussion on those areas?
Yeah, of course, this is very much focusing, you know, for bold MRI, this is not very easy, because you would have to inject markers of hypoxia like piminodazole, as we do in animal studies. This is not very easy in humans for ethical reasons. Of course, there's many data on fibrosis and diffusion weighted imaging with very nice correlation, and probably quantification of fibrosis is for nephrologists really of major importance. And I'm a bold lover, but probably even more important than measuring oxygenation, right? Because this is where we really can have an impact on follow-up of patients. Think of the patient with glomerulonephritis, where things are not going very well. You wonder, is it the fibrosis that is increasing, or is the glomerulonephritis active again? Do I give immunosuppressive therapy or not? And this is where diffusion MRI could have an important role. And many initiatives are validating quantification of fibrosis against biopsies, but with the little limitation that the biopsy will say that it's so wonderful, but it remains a microscopic part of the kidney. If you biopsy in the zone of fibrosis, you're going to overestimate, and MRI doesn't have this problem because you have the whole kidney. So I think there's a lot to say to use much more functional MRI in these situations.
I think
not there.
Go on, Keith. Sorry,
I think
going to say the same.
Literature, yeah, we probably were going to say the same, Nick, but the most literature in this is in the transplant field, probably. In the largest study was the Wang paper published last year in JASN. I think it was about 160 transplants, which did show quite strong correlations, both with ADC, which is a diffusion measurement, but also with cortical T2 star, I believe, as well, so a bold measurement. So certainly the greatest literature is with diffusion, as you say, Menno. But yes, it's additive rather than replacing biopsy. I think that's probably the most important point, that, you know, patchy diseases like glomerulonephritis or acute rejection can be patchy and can be missed by biopsies. And so functional imaging would give a much more comprehensive evaluation, perhaps, of kidney tissue, and might even be able to be used to target biopsies, so to try and highlight areas where there's less fibrosis and potentially more rejection, to allow those patients to then undergo biopsies at the appropriate site. So I think the main message is that it's additive rather than replacing biopsies.
Yeah, I completely agree.
And there's also the Friedley paper that has correlations with fibrosis and T1 measures. So the course combinatory differentiation in T1 changes with fibrosis as well. So it's another measure to group with those as well.
Mm-hmm. I just was thinking again about Keith's comment. I don't completely agree. After all,
for that very
because one of my main ideas is still that in the long term we will have certain situations where maybe we won't do the biopsy if the MRI has shown that there's not a lot of disease activity, either quantified as a lot of fibrosis expressed in ADC changes, or not a lot of inflammation, etc. So I really hope that we're going to get there, and that we can reduce the number of biopsies our poor patients have to undergo. It will never completely replace, maybe, we don't know. but I think it will help to reduce biopsies.
I think that's a good point. I think there's a role to identify if there is viable kidney and a treatable inflammatory condition versus just fibrotic kidney. So yeah, I do agree that there's maybe a role in screening patients for appropriateness for biopsy, even if there will always be a need for biopsy to kind of diagnose conditions at the cellular level, as often is done.
And what's your thoughts then on with imaging? Obviously you get all of the slices, you get all the coverage, you can start looking at things like patchiness of the kidneys. So how would that change your choice if you were doing your biopsy based on that information?
I would, it's an and situation. Probably if I already hesitate whether I should do the biopsy in this patient with long-standing glomerulonephritis, who has, yes, an increase in proteinuria, but who has already had quite a bit of immunosuppressive medication. If I would get the result of the functional MRI that would really see advanced fibrosis, I would not do the biopsy, and I maybe will just follow up. But at the moment, we don't have data for this. The first case reports start to be published now. There was a nice one by Anna Caroli recently. So it is going to come. And but there will be, I think for me, the place is biopsy or not to biopsy. Of course, for the diagnosis, you cannot simply replace the biopsy by MRI, not at this time point. But to for example, perform an MRI, instead of now we do ultrasound in every new patient with CKD, why not do an MRI? I think the coming 10 years, the cost will come down if this can give you the same anatomical information and much more, and helps you to predict the outcome of this patient. For ultrasound, we are not there yet. You know, we have a few papers on the resistive index. It's another subject, very interesting too. But the MRI, I think, can be much more informative and precise on this subject. And if you're so lucky to have any MRIs around.
So a second role as well, not just prognosis at baseline, but actually a repeat MRI to track changes that we can't see yet, just by looking at EGFR and albuminuria. And I think that also gets back to the question about, can we do better in how we evaluate new drugs? And that's albuminuria and EGFR are all we have at the moment in many cases.
And I think it's not just availability and cost, Menno, but at every stage of the procedure, things are probably getting a bit better. I think scan time's coming down, scan acquisitions becoming more homogenized, analysis is becoming more automated, which makes the whole procedure from scan to analysis far quicker.
And I think it's that standardization that's really necessary to actually then promote all of this work. There's another question in the chat. Is there a role for bold protocols or arterioscreen labeling for using MRI with contrast in patients with severe CKD or end-stage renal disease in place of gadolinium or CT contrast?
Could bold MRI replace contrast? Would you read it like that, the question?
Yeah, so I guess the question is, could in patients with severe CKD or end-stage renal disease, rather than using gadolinium or CT contrast, would you use bold or ASL?
Well, it depends of your question. I think when you use gadolinium or contrast in end-stage renal disease patients, it's usually either to characterize better a tumor that has been found, or to identify renal artery stenosis. For tumors, I don't think it can just replace. I would not think of bold MRI. For renal artery stenosis, I think there are opportunities for not only bold MRI, but also in combination with phase contrast to quantify renal artery perfusion, arterial spin labeling, diffusion weight. Imagine you have a patient with a renal artery stenosis, you hesitate, should I dilate or not? If you would do a bold MRI and you inject furosemide, as the Mayo Clinic has done several times, there's no more change in R2 star, you could say, well, these tubuli are dead, they're not doing anything anymore. Maybe you would not be so eager to go and dilate. If you have very high R2 star values, this may be a sign of a suffering kidney. In this case, you would more easily decide to go for it. All this is not clinical practice. It's very much research setting. We're in this exciting phase where all these protocols are better and better validated. There's consensus now. We now need the big vendors to incorporate this in their usual scan setup, and we need faster ways to analyze the images, and that's maybe partly going to be done by universities, but we need these Philips, Siemens, whenever they're watching, to bring this closer to practice. You know, the applications are clearly there, and I think now we really need help to have a practical product where we can get an answer very quickly, because analysis time is still pretty high.
I think along the line of that question was also, is bold MRI being used in other organ systems or diagnosing other diseases, that it may be something to be aware of, to ask for in our CKD patients, as opposed to the more traditional imaging tests we're using outside of the kidney?
Mm-hmm. I'm not sure I can answer the question. I know that bold MRI was before Prasad already used in the brain to measure brain activity. Does anyone else know if in the oncology world it would have some applications?
I think, as you say, they're all kind of small studies and under academic review, but there's no kind of clinical product that could be relied upon yet. They're all sequences that were developed in neuroimaging, and so they might well be used in the setting of acute stroke and so on, but they wouldn't tend to be appropriate to be used in place of contrast enhanced scans. But I guess there are novel contrast agents that are becoming more widely licensed, like femoxetol, like Menno mentioned, that might have a role in replacing gadolinium and iodinated contrast in our patients.
And another place where it's used quite a lot is just looking at oxygen enhanced studies. So so in the brain, it's used in response a lot to kind of activity, getting people to perform tasks, but there's a lot of work that's also going on looking at oxygen enhanced, so at rest, and then getting people to breathe oxygen, or looking at CO2 challenges and looking at those to modulate the changes that are happening in other organs. So that's other areas where it's being used. Oh, and Dave Buckley said that
slightly different from bold,
yeah,
but one of the best sort of examples of.
Could you repeat that, Nick? Sorry, we missed that.
Sorry, I think my connection just was a little bit unstable there. I was just going to make the point that moving away from bold slightly, one of the best examples of translation of multiparametric MRI to a clinical setting has been for prostate cancer. And so now common to see a sort of a report with multiparametric data and then a sort of a qualitative report from the radiologist at the bottom of that. And maybe that's the sort of area that we eventually want to get to with the kidney.
So a couple more questions. Can this help differentiate CKD, AKI, AKD? I think we've covered some of that, but does anyone want to have another comments on those points?
I think in our small pilot study, we saw a difference between bold measures in AKI patients and in CKD patients. It was in very small numbers, but we saw a lower R2 star in AKI compared to CKD. But I say very small numbers, so it would need to be a bigger study to say for definite.
And I think, as you say, Charlotte, I think what that reflects is a need for kind of harmonization of sequences across different centers, as well as much bigger studies. So a lot of the imaging studies are maybe in a few dozen, or at the most maybe 100 patients. But what we need is much bigger multi-center studies of hundreds and hundreds of patients, which are underway in terms of the AFFIRM study and the IBEAT diabetic kidney disease studies. But I think these much larger studies will help to characterize the role of functional MRI in CKD, especially.
So I think that's picked up all the questions that have been posted in the chat. Can the group recommend a software package to standardize bold analysis? Oh, so that's a good question. That often it's the acquisition that you can do, and then it's how you then move forward to the analysis. I don't know, Menno, do you want to start on that topic?
Oh God, I thought this was a perfect question for you, Sue.
I'll come in afterwards.
My dream is to have this software package. My software package used to be a PhD student analyzing the images in MATLAB, but that's not the answer. Anyhow, for telco, I have shared it with many, as you know. This is a MATLAB algorithm that is going to be out on different websites soon, and whoever wants to use it so far contacts Lausanne, so basically me and Bastien Milani, to get this algorithm, and we share it. So this is out, and I think better probably through different websites where this type of MRI software is shared and can be downloaded without having to pay or pass by difficult commissions.
Yeah, so I think as groups, then people are definitely working together now to actually harmonize and share software, and software is then becoming much more available on GitHub as well at the moment for people to download, and people are making their software available with papers. I think there is a need, as you say, to not just harmonize the acquisition, but harmonize the analysis, and then make that easy, and have some of this also being integrated on scanners. So if you can run all of your analysis, analyze on the scanner, have that all integrated, and that's where we really need to also work with the MR vendors to actually have an entire package, or a post-processing package that's available, like you have with cardiac MR, that you can link with your scanner. So I think this is an area that, and the more people that are working in the area, the more push we have with MR vendors to actually set this up. Yeah.
And I guess it goes back to drug development, as Nick's mentioned a couple of times. The more that pharma are interested in this topic and using kind of multiparametric MRI to evaluate kidney physiology, the more pressure there will be to vendors to actually create a product that works for them. It's always worth bearing in mind that total kidney volume is the only imaging biomarker, and I think the only renal biomarker apart from EGFR and albuminuria that's approved by the FDA. That's for tolvaptan prescription in PKD. So that there is certainly pharma interest in this, and there are, there's a pressure for vendors to start helping out.
And I think with all the kind of new machine learning algorithms as well that's available, to try and take away the to make it more automated, taking away the manual nature as well of a lot of analysis will be key, particularly if you want to do these large kind of pharma studies. We need to have a push in those areas. So can we put a plug in for the Isomer sponsored renal workshop in the fall? Definitely, yes. So so there is going to be an Isomer workshop that's going to be that's going to be held in the States, but obviously now we're much more used to a virtual setup. Then part of it will also be a virtual meeting as well. So I think that could be advertised as well through these groups as well.
No, this meeting is really going to be unique, by the way. It's because it's a joint meeting that takes place next September 2021 in Philadelphia and in Lisbon. So it's different time zones having a congress more or less at the same time. It's not going to be virtual, so we do hope that everybody will have had his COVID shot by then. But this will really bring together all people in the functional renal MRI field worldwide, we hope, and there are practical workshops, and there is an update on everything that's going on in this field.
Great.
And it's, I think, 9, 10, 11 September, or 10, 11, 12, something like that, 2021.
So where is it going to be based in Europe now? Is that?
In Lisbon,
Right. Okay.
Portugal.
Great.
And Philadelphia, United States.
Great. So, Keith, did you have any other points that you wanted to?
No, I think we've had a good discussion, both of BOLD and also highlighted the value of a functional, a multi-parametric approach to functional MRI, that all the sequences complement each other and hopefully provide different evaluations of renal physiology. And I think that's a nice way to wrap up, to highlight that there is ongoing work, both in big studies as well as some of these workshops in the big congresses in radiology as well.
Great, thank you. So I guess what I'll just wrap up now and just really thank Menno for his excellent talk, overview that really kind of started all of these discussions going, and thank everyone for attending today and interacting on the chat with some great questions. So thank you.
And really, my apologies to the beginning, and I was saved by Ann Zanki. I have the feeling I'm online as Ann Zanki now. She's my colleague endocrinologist. Thank you, Ann. And thank you all for having organized this. It was a pleasure seeing you all and participating.
Thank you.
Thanks very much. Cheers, guys. Thank you.
Thank you. Thanks everyone for joining. We'll be back on this Sunday again with another GlomCon session. So thanks everyone. Have a great rest of your day or evening.